Am I audible? Can you all hear me? Hello everyone, and we will just wait for everyone to join in, and we will then start the session shortly. So let's just wait for 2 minutes. Good evening to all of you. So we're just waiting for people to join, maybe just for 2 minutes. Thank you all of you for joining in. Should I open the books? I hope you all are doing fine, and I wish that this session will be helpful for you all. And when the participants are joining, quickly we will have Mr. Karl Khan with us on the topic discogenic neck pain. So, just 2 more minutes, and then we shall go ahead without wasting any time. Hello, everyone. Hello, guys. Thank you for joining in. So, I think we can just start with the session, and at least we can start with the introduction without any delay, so that meanwhile people can start joining in. So, thank you all of you once again for joining us for this webinar. And our today's guest is really special, and he is practicing like really well in this field. So that's the reason we have just requested him to come and share his experience with all of us. And without wasting any time, I would just like to call Mr. Karl Khan to just get added. So, Karl, if you can hear me, can you please join the room so that we can start?
Hi, Samantha. How
Hi.
are you? You
Hi,
okay?
I'm good. Yes. So, let us first of all thank you for joining us over here. And before starting, I would like to tell you that we have got almost 1,000 registrations, and we have students from various countries today, and they all are looking forward to learn from you. So, yes, before starting, I would like to just give a small introduction, but I would like you to speak more about yourself because we would love to hear you, and that's the reason we have arranged this. So, for all the participants who have joined, Mr. Karl Khan is a clinical director of the chain of London Pain Back Clinic. He was initially working in NHS, and now he has moved to his private practice of chains of clinic. Now he has worked in UK and USA both with the teams of Tucson, Arizona and Washington DC. And he is specialized in variety of treatments, especially in orthopedic, musculoskeletal and sports. Now I would really like Mr. Karl Khan to actually go ahead with the introduction and explain us till the time we have all the participants joining in. At least share about what the chain of London back pain clinic is all about and about his speciality and specialization. So please, sir, go ahead, and we all are waiting to actually hear you. Just 1 second before going ahead. I'm
No
so
worries.
sorry to interrupt you.
That's okay.
Yeah. So basically, for all those who have joined this, please attend the entire session, because at the end of the session, we will be giving you a question and answer form to fill, and you have to score at least 50% in that to get the certificates. So, all the best to all of you, and sir, you can please go ahead.
Are you ready? Are you good?
Yes, yes.
Brilliant.
Yes.
Thank you, Samantha, for having me today. And thank you guys for coming. I really appreciate it that you're taking the time to listen to me. So let me tell you a little bit about myself. I'm the clinical director for the London Back Pain Clinic. We have 4 different sites across the London. So in the City of London, over in our financial district in Canary Wharf, over our medical, kind of private medical area of Harley Street, and over into South Kensington. Now, we're not just a bunch of physiotherapists, so we've got a team. So we've got osteopaths, chiropractors, podiatrists, psychotherapists, and we work as one big MDT. We also got a sports physician as well that we work with, and we also work very closely with a spinal team called Complex Spine that have pain consultants, surgeons, and radiographers. So we work very closely as a big MDT, which we'll discuss a little bit later on in the presentation. So a little bit about myself is, yes, I did work a little bit. I worked a bit in the start of career in the NHS, and I slowly kind of progressed towards the NHS side. And then I started having a little bit more of an interest in some spinal therapy and sports. So, for example, we are the sponsors for East London Hockey Club, which is the second biggest adult members club, hockey club in the UK. We play at the national pitch, which is really nice. And so I guess I have a little bit more of an interest with regards to sports injuries in hockey. With regards to, if you guys want to know a little bit more about ourselves, okay, we are on Instagram at London Back Pain Clinic. And if you want to have any questions for me, if you email us email me personally at Karl at London Back Pain Clinic. I'm always here. And if you guys want to do any kind of mentoring or anything, like you want to come down and we do some kind of work together, by all means, ping us an email or follow us on Instagram and we can get that sorted. So today we're going to talk a little bit about discogenic neck pain. So I'm going to keep it quite basic today. We're not going to go anywhere too advanced. Okay, I'm going to try to talk more about the mistakes that a lot of physios occur. So we'll take a little bit of a background about neck pain in general. We'll talk about what we found on MRIs and X-rays. We'll have a discussion if X-rays and MRIs are actually needed. We'll have a little bit of a discussion again about acute and chronic injuries and the differences and what you should watch out for and what things that you will see in the future of your practice. Now I'm going to talk about the subjective assessment. Now, very, very important part, and obviously we all know the basics, but the thing is we can always improve on it, and that's what I'm going to go through today on that. I'm going to talk about some false beliefs that can kind of hinder our kind of performance or the outcomes as a therapist. Some objective assessments and how I like to conduct my objective assessment to kind of guide my treatment more effectively. And then we will talk about some common mistakes, and then again I'll talk about how I work with an MDT, both in my own clinic and with the surgical side. So let's just quickly give you a background of neck pain itself. So as we know, 48% of the population will generally get neck pain at one point in their lifetime. Okay, so it's very, very common. So it's a good one to actually tell patients from the get-go. Okay, 26% of the patients will get it in a year. It ranks 4th on the global disability scale. That's in line with lower back pain as well, but as a spinal injury. Now, it tends to occur more in higher income areas, but with low to mid-income countries on the rise, with desk-based jobs also on the rise in these countries. And also the majority of pains tend to go away very shortly. Okay, so that's a very important thing right there to remember. Now, what are the common causes? So according to Beer, it's generally tend to be a sedentary lifestyle, long periods of poor posture, okay, previous accidents, previous MSK injuries, like shoulder injuries, upper back injuries, even lower back injuries. The previous accidents could be a whiplash, for example. And then the high load, kind of repetitive nature jobs. So for example, being a hairdresser with your arms up here all the time, again, sitting at the desk because your head is at end range all the time. Dentist, head looking down at end range all the time. And the other big thing that a lot of the time we miss as practitioners is a change in load. Okay, so how do I mean by a change in load? Say, for example, this could be, one day you're in the gym and you normally lift 10 kilos, but for some reason you decide to lift 20 kilos, okay? And that's just a little bit too much for your neck to handle, or you put a little bit bad posture because you compensate, and then that causes an inflammatory response. Okay, so changes in load can be anything in day-to-day life. It could be carrying the shopping, it could be sitting at your desk more, it could be changes in your desk thing. So really, when you do your subjective assessment, look for these changes in load. Really important, because then you can educate further. So we're going to go over pain just very, very briefly, okay? Because I know you're all learning about it, but it's good to know, just if we catch up. So obviously we have our nociceptive pain, which is pain. Obviously, it's just tissue healing. We generally say about 3 months. Certain injuries may take up to 6 months to a year. Perceived pain. Now, this is a very interesting one. This is the brain's way of kind of giving out pain. So say, for example, I hit my hand, okay, and I don't feel really much. And then I look at it, because my hand is now, got a nail through it, for example, there's a lot more pain, but there wasn't any pain when I didn't notice it. Okay, so if you guys look this up on YouTube, this Lorna Mosley, there's a really good kind of like, it has a good experience about it, and it helps you with it, helps you understand it a little bit better. And then we got our neuropathic pain, which is our kind of radicular kind of symptoms, our shooting pains, our sciaticas. Again, just a good one, obviously, with this pain's good to know. So more importantly, though, what drives our pain? Okay, so a lot of the time is that this is what we kind of miss, and it's more that these drivers of pain can kind of stop us going forward as practitioners, yeah, and they could be the things that limit us. So a lot of the time, stuff like physical stress, fear of movement, joint changes, anxiety, depression, work stress, social stress and frustration, lack of sleep and support, and these false beliefs, which I'll carry on with a little bit later. But these kind of things can obviously elevate pain levels. That perception of the brain kind of keeps that patient in pain. They're not getting better. And again, that's what stops their healing. And it comes when they lead more into those kind of chronic pain syndromes. So let's go over the basics. What is a disc injury? Okay, so many of you may know that it's a lot of the time it's this little nucleus pulposus that pushes out, okay, or bulges out through the annulus fibrosus. And what happens is it can sometimes compress the nerve, okay? Also, what we think. We get different levels of it. We get bulging, we get a little bit of protrusion, and then we get the extrusion, okay? Now, a lot of the time, most of the time it's bulging. We can also get some disc degeneration where the disc narrows slightly, and then you see that a little bit in older ages. Now, a big kind of thing that we always think of is that, or patients in particular think of, is that this bulge is pressing on the nerve. In actual fact, a lot of the time, it's just the disc may be a little bit irritated, and it's the inflammation around the disc is irritating that nerve, causing the pain. Okay, obviously you do get at times where there is compression from the jelly on the nerve, but a lot of the time, and the majority of the time, it's just inflammation around that area. Okay, so let's have a look at the radiological findings here. Okay, so we've got a nice little picture of a bulge right here, kind of compressing the cord here. And this is a lot of the time what the patient will kind of see, all right? But in actual fact, 90% of radiological findings are not specific, okay? And if we, in this study here, over 1,200 kind of candidates who had asymptomatic symptoms, nearly 90% of them showed to have some sort of disc bulging, but obviously no pain, okay? And again, 37% of people at the age of around the 20s had disc degeneration. 97% of 80-year-olds had disc degeneration, but no pain. Okay, so a lot of the time, our radiological findings can be a little bit misleading, and again, can actually cause a little bit more anxiety in the patient because they think they have this kind of condition going forward. So this brings me on to my next thing: is do we need a scan or not? Now, I'm obviously saying that we don't need MRIs. MRIs don't have a place. Totally, no. I do think they do have their place, but I feel like if you need to refer a patient for an MRI or an X-ray, you need to justify the reasons why. Okay, is it more of a serious condition, or do you feel like if you do refer them, is it going to cause more anxiety with them? Okay, because a lot of the time people will get fixated on this disc injury when we know a lot of the time they're asymptomatic, and these MRIs are just a picture. So what happens when you do get that patient with an MRI. Okay, and this does happen a lot, and you'll get it in the future. Now, it's not yourself to focus on that disc injury itself, because if they've had it over 3 months, the healing process is already done. So it could be psychological effects or even mechanical, or they've just been compensating for in different ways. And again, you get that perceived pain. Now, so what I would say to a patient is I would have a look at their scans, okay? Now, obviously your reaction is very, very important. So you don't just go and look at it and go, oh, yeah, because that's going to strike anxiety and fear. Now you have a look at it, yeah, make sure you look at it, you go, nod, adjust it, make sure you give the time to read it properly and thoroughly. And then you say, these look very, very common. You can relate it back to the research, the radiological findings, okay? And then you can reassure them, your scans look healthy, they're perfectly normal. And again, you back it up with that research. So let's discuss a little bit about acute pain. So a lot of the time when they're going to come in with acute discogenic pain or neck pain in general, they're going to come in with limited range of motion. There's definitely going to be some nociceptive pain. So a lot of tissue healing. You may have some neuropathic pain, so you might have some symptoms going down the arm. And also you're going to have some perceived pain because you're going to have that anxiety, yeah, towards movement or doing activities. A lot of the time they're going to have a fear of the future. A lot of the time you're going to get that this is going to become my new normal, but this is one thing that we can help as practitioners to calm them down. Okay, they're going to be compensating to avoid the pain, and generally their pain comes on, like I said before, due to a change in load. Okay, and sometimes you do get a potential acute symptom on a chronic injury. Okay, just obviously bear that in mind. With those kind of patients that have had acute injury and a chronic, I would say if you can calm their symptoms down, get them back into their normal baseline, and then if you find a way of them to manage the pain, you can teach them that way of managing it, and you keep them repeating it. So what is our roles with regards to acute discogenic pain? So our roles as physios, it's not necessarily to fix, it's to kind of guide the patient through the injury while it heals itself. Okay, it doesn't sound too exciting, I know that, but you're going to prevent a lot of problems for this person going forward. Okay, so it's really, really important that we don't cause too much, we don't cause any anxiety, and we get this patient motivated to get back into their normal activities. So things that you can do is, I would never, if I suspected disc pain, I wouldn't necessarily say it's a disc pain. I would say, you're stiff here, there's a little bit of inflammation, this area is irritated, there's muscle spasming, keep it simple. Okay, so it's simple for them to know as well, and they can understand it, and it doesn't sound too frightening. Yeah, and also if you think it's a disc injury, I'd always err on the side of caution, particularly if you're doing stuff like manual therapies or exercises. You don't want to be too aggressive, and you set it off and it goes further back. Okay, so a lot of the times with discs, they can get worse if you don't treat them with the respect that they deserve. Make sure you got to educate the patient. This is a normal thing. Neck pain is normal. Again, 50% of the population have it. 26% will have it in a year. It's perfectly normal. Majority of the time it goes away. Again, educate on timelines about healing processes. You can say this is going to be probably around a 3-month process at most. Okay, majority of the time it tends to go away after 2 to 4 weeks. Okay, you can use, as a therapist, you can use your pain gating techniques to help the patient manage with their pain. You've got to remember, we're not miracle workers. Okay, we're not going to come in after one session, that's it, they're solved. Some patients that does happen with. Okay, I'm not saying that it's not unheard of, but you've got to remind the patient as a process. Okay, you're going to say, look, there's going to be an injury, you're going to get a little bit weaker, you get a little bit tighter, and we've got to sort that out, and we've got to help you along your journey of this neck pain. So the biggest risk for a patient with acute injury is psychosocial factors. Okay, patients getting anxious and depressed with low mood, okay, and a fear, okay, of moving. because that means they're not going to be able to, they're not going to be doing their rehab, they're not going to work on getting stronger. What's going to happen is that they're going to get anxious, and they're not going to get through this, and they're going to compensate. And by the end of 3 months, it could be an entirely different injury altogether. And the other thing is long sustained awkward positions, like this gentleman over here. So basically, especially in today's society where people sit at desks. Now, I'm not saying posture is a cause of neck pain, but it's definitely a contributing factor. So, for example, if you're sitting there all day at end range, or the best way to describe it is have your finger in this position, and you keep it at this range. It doesn't hurt at the moment, but if I kind of stay there, after a while, it's going to hurt. And this is the same thing. If I'm sitting here like this all day, okay, after a while, those tissues are going to get agitated, they're going to get inflamed, okay? And especially when you have an agitated disc, again, that's going to delay that kind of healing process, and delay that kind of delay that heal process and the rehab potential. So let's go over chronic injury a little bit. And again, you will see lots of these, okay? So a lot of these times, these patients will come in, they're going to be frustrated. They're going to have seen lots of different practitioners. They've probably seen chiropractors, they've seen osteopaths, they've seen physios, they've seen surgeons, they've seen pain consultants. You name it, they've seen it. Yeah, they've tried everything. They've looked through YouTube, they've looked through Google, and they're looking, to find that fix. Okay, but generally, 9 times out of 10 will have some MRI results, and they tend to actually focus a lot of the time on the disc. Okay, and again, it's our jobs, which I'll get to in a little bit. A lot of the time, they'll have an incorrect belief system about their injury, and again, there's a lot of psychosocial drivers. Okay, so our jobs in this case is to re-educate the patient about their injury. Okay, it's not necessarily the disc. The disc is healed. Okay, it could be more mechanical issues. Yeah, you can educate on the scans. I know it says the scans here, but if you scanned my neck, I'm not in any pain, but it'll probably show something similar. Educate on disc health in general, and then re-educate them on their beliefs. And re-educate them again. Exercise, really important, and movement. Movement and exercise are not going to cause any damage. And then, obviously, in the best of your ability, you use your physiotherapy knowledge to improve their symptoms to the best of your ability. And then we liaise with an MDT, okay, which I will get onto towards the end of the presentation. Now, the subjective assessment, okay, so we know that we have to get our AGs and EASes and our 24-hour patterns and our kind of basic red flags and all this kind of jazz. But I want to tell you about how we can always improve our subjective assessment, okay? Because a lot of the time, especially on the first meeting, this is our kind of selling. We're selling ourselves at this point, okay? The person's come to you and they're in pain and they want to know that you can fix it. They need to trust you, okay? That is really, really important. So first impressions do matter, okay? The first thing I would say is you have to listen to the patient, okay? I've kind of mentored other students in the past, seen other therapists, and they don't listen, okay? And it frustrates patients, okay? They interrupt very shortly and let the patient talk, okay? And I might have been guilty at this in the past as well, when I was a little bit more junior, because I got told by one of my educators that, if a patient is rambling, you should, maybe you should cut them off and bring them back to the center. But no, they're trying to tell you something. They're trying to get their anxiety out. In a way, they're trying to get it all out, and it's going to help calm them, okay? And it also, if you attentively listen, so with your yeses and ums and ahs and nodding, you're gonna, they know you have your best interests, okay? A good thing here is what you got to do is also relate to the patient, okay? So if they're saying that I can't play my sport, I can't exercise, okay? Relate to them, for example, or if they can't do the shopping or however, relate to them, sympathize with them, okay? Say that you've been in similar situations, or if that was me, I would be really frustrated, I would be really upset, okay? Get down back onto their level. Another one is obviously figure out their drivers with the questions that you ask, which I will get onto in the next slide. Now, the good thing is educate the patient on their aggravating factors, okay? So a lot of the times when I was talking about load, so a lot of injuries, particularly with the neck and the disc, is that it can be irritated by certain things. So if, for example, I had a patient the other day, they came in and they said they were getting pain when they were carrying the shopping, okay? So what we did was we kind of simulated the same sort of thing, and then we worked out that if they were carrying something that was particularly heavy, around 7 kilos, it started to bring on those symptoms. Okay, so then you can educate them that, all right, so we're going to do these exercises to strengthen this region to help not bring this on. A good little tip for you guys to do going for the future, I wish I learned it earlier, is motivational interviewing. Okay, so the psychotherapist that we work with, Sean Roberts, was teaching me about this the other day. And I tell you what, it's really helped with my questioning the patients. I get a lot more out of them, and especially with the chronic pain patients. So I'd really, really highly recommend that one. Short-term and long-term goals are a must as well, because especially if someone's anxious, if you have something to work towards, it does help using the short-term ones to give that little bit of a reward centers, and that long-term one to know that we're back. So let's discuss on some good questions to ask. So first thing is what do you understand about your injury? Now, a lot of patients will either say, especially when it's a disc, you say, oh, the disc is protruding on the nerve. Some of them say, I don't really understand. They've seen so many people, and they get, again, they're frustrated. They get a bit upset about it because they don't know what's wrong. Okay. Unfortunately, they haven't been trained, like us. And that's why we're here. So I'd say, again, like before, keep it nice and simple. Okay, the more simple, the better. What the next question is, what do you think is causing your pain? Okay, so with this will give you an idea again of where the patient's belief systems are. So say, for example, I got told it was my discs. Perfect. And then we can re-educate that patient on their kind of cause of pain or their belief system. Have you consulted Dr. Google for your injuries or exercises? And this is the big one, okay? Because a lot of patients, especially in today's society, will have consulted lots of Google stuff, and obviously Google catastrophizes everything, and then they've seen lots of different YouTubers as well, and they're like, oh, I've been doing this exercise, but I don't know if it helps. And a lot of the time, because of these exercises tend to be quite generic, they could work, they could work, but if it's not, it could be obviously making things worse, or it could be giving, again, that false belief system. Because again, I've watched a few videos up there, and a lot of the time what they're saying is just going to cause more fear and more anxiety, and also stop them from doing the things that they like doing. A big one here, what do you think you need to do to improve your pain? Now, this is a really good question here, because then it also gets a sense of what the patient is feeling right now. So they're feeling like, oh, I feel like I need a massage, for example, or I feel like I need to get a tissue release, or I need to strengthen this area. Again, it means that you can also work with the patient, and you can understand. So maybe I need to do a little bit of manual therapy if they're saying they're a bit tight and they're stiff and they need this. But then it means I can also help sell them to my treatment program as well. Okay, or you can also, big question here is, what is your biggest fear? Again, a lot of the time these patients will always have fear, so again, you can figure it out, and then you can kind of refute that kind of false belief from the get-go. And the next one is, what tasks or hobbies are you avoiding due to your pain? Again, patients may say, I'm not running, for example. Okay, fine. But what you can educate the patient on is movement or pain doesn't mean damage, okay, for example. Again, you can calm their belief systems and make them a little bit happier, and again, see a little bit more light at the end of the tunnel. So these questions will give you a good predictor of the outcome, okay, of the patient and how they're feeling, if they're yellow flaggy at all. But again, it will also help you kind of combat those false beliefs, which I'll talk about now. Now, just another thing that, again, I used to maybe making mistakes on when I was a student or in my first couple of years is that I used to want to really impress patients, okay? And so, you really got to like, oh, this muscle's weak and you're out, your hips are not level, or, this muscle's not working. And basically keep it simple, okay? This is stiff, it's not moving correctly. There's a little bit of compression there. This area is a little bit irritated. Don't go in there trying to impress, okay? Because they're going to come out and thinking that everything's wrong with them, okay? And again, that's going to give more fear to the patient, and again, stop and potentially stop us from getting to that goal. I can't move. It will make things much worse. We know our bodies are supposed to move, so let's move them. Our bodies like to move, okay? And again, as movement specialists, we can educate those patients on, ways to move safely or more therapeutically. My muscles are tight. Now, I do get this because a lot of the time it does feel, particularly when we have those kind of discogenic neck pains, we get those tight upper traps, those trigger points, and a lot of the time the patient kind of identifies the pain to that and they think they need trigger point therapy. But as we know, it is generally referred from the spine. Again, it's us to educate, and with not necessarily tight, sometimes muscles can also be weak, okay? And it all goes down to our assessment, and then again, you educate further on. My posture is bad, my posture is the problem. Again, Google and YouTube and stuff like that has a bit of a price to play for this, because everyone wants this perfect posture. And I think, if you look through time, people have always focused on having perfect posture. Again, there's no particular study saying that posture is an actual cause, but like I said before, going at end range, putting your finger in this position for a little while, okay, it's going to start hurting, okay? So that's what you, again, educate that patient about. My disc is the problem, and like I said before about the radiological findings, majority of people will have some sort of disc pathology. Most of them will be asymptomatic about it. Big one here is I am out of alignment, I am rotated. Again, there's no, everyone's maybe a little bit out of alignment. That's probably not the cause of it. Otherwise, we'd all be in, pain. So again, educate, reduce that fear, get that better goal. All right, so we're going to go over a little bit of the objective assessments. We're again very, very basic, and then we'll kind of talk about how it kind of helps guide my treatment. So we'll, for example, with the C-spine, I will always look at C-spine range of motion, and I will always look at the way they do it, the motor control, the quality of the movement. Now, I would have a look with their posture. For example, are they in a flexed position like so, or are they in a extended position like so? So the flexed one is we're very upright like so. So we lose that lordosis around the top of the neck, okay? Or we're in the common kind of poking chin position, and we're extending through that C3, C4 region. Now, T-spine, again, are we slumped or we're very upright? Is our T-spine in an extended position or is it in a flexed position? Okay. The shoulder girdle, is it winged? Is it over retracted? Okay. A lot of the time, sometimes you will see patients that are really, really retracted because they've been told they've got to really work on their posture. Are they rounded, for example? Have they been sitting too much at the desk? Have they got a depressed shoulder to one side? Is there an elevated shoulder to one side? Shoulder, I would have a look at also the shoulder range of motion and the quality of the movement, and just to see if it could look at if there's any kind of weakness around the scapula. Strength testing and length testing of muscles. I do this. Again, good ones to look at is like the latissimus dorsi for latissimus dorsi and pecs. Again, you've got the levator scap and upper traps for length testing. Strength-wise, it's always good to look at the deep neck flexors to see if the SEM is kind of, or sternocleidomastoid or is overreactive. Again, good to look at serratus strength, for example, okay, or the quality of the movement when lifting up. A lot of the time, you may see that the serratus is not working properly. A lot of the time as well, people think that the upper traps are tight, and sometimes they're not. They're just underreactive. And then it's always good to do a good neuro test, just especially if they got neuro-type symptoms. So how does this help us with our treatment? So like I said before, the objective holds all the clues, okay? So what I like to do is, say for example, we have a restriction with range of motion, okay? Now, I say we got a restriction into extension with range of motion, and they look like, if I need to do is I need to give an exercise, for example. So what I might do is if I feel like they're hinging from that C4, C5 region, and then I'll do some retractions, okay, to mobilize that C5, C6, C7 region, okay, and then I'll get them to do extension again. If it's proved, perfect, I have a positive test, and that's called a directional preference, okay. Other things to have a look at is if you give an exercise and it reduces pain or it centralizes pain, okay, so it goes like from the arm or around the shoulder blade and goes closer to the spine, okay. Other things that I may do is I might test the neuros. So if the neuros improve with the exercise that I'm giving or the kind of modification that I'm giving, then that could also be a positive result. So things that you could do, like I said, you could do an actual movement itself. So for example, you could try retraction, going to one side, or going into rotation. And if it improves any of these symptoms, then we've got a positive right there. I may engage a muscle. So for example, I might do some serratus work, okay, or I might lift the upper traps up or start engaging the rotator cuff. And if that gives an improvement, then on any of these symptoms, then I know where to guide my treatment. Modifying posture, I know I said about posture beforehand, but like I said before, is that sometimes people are really retracted, so I might get them to protract a little bit more, or I say, for example, they're really, really extended at the T-spine, and I flex them slightly, and their range of motion of the neck improves, then I know I've got a positive test. I need to do a bit of T-spine work, for example. Or if they come in slumped and I bring them upright and then their neck improves, then again, I know I need to probably work on their general sitting posture. And then the last one is a mobilization with movement. Okay, so for example, again, if we're a lot of the time, especially with those extensor issues, if we're a bit stiff around that C5, C6, C7 region, then, and we want to work on extension, I might do a little mobilization with movement with my own hands, okay? And if that improves it, then I can get them to repeat that exercise with a band, giving a gentle mobilization and then going into extension, okay? But obviously this is very broad. If you want me to go further in depth, I can do another kind of talk on exercises being a little bit more specific. But for future, doing like the Mulligan's course is quite a helpful one, and also the McKenzie in particular. Okay, so let's talk about common pitfalls with regards to treatments. Like I said before, posture is causing my pain. It potentially could be, but that's not always the case. It's not always the case. And again, a lot of the time it gets victimized. If you do get a positive test on a modification of a posture, perfect. If you don't, that's probably not the issue. My pain is caused by muscle knots. I mean, I do trigger point therapy, but it's more to kind of help with patients' pain levels. Maybe I might do a little release work, again, to release a tight muscle to see if that's maybe overreactive. But majority of the times, it's probably not a muscle knot. It's most likely the spine itself referring, or the disc itself referring pain, around the shoulder blades, tops of the shoulders. Okay, like we have this picture here. Scapula back and down. Okay, always the scap setting to make that perfect posture again. Sometimes that can be, and I've seen patients where they've came in with that false belief, and they're like, oh, I really need to be in this perfect posture. A previous physio told me this. And they've got very overreactive rhomboids, and they've got very overreactive low traps. So, and sometimes it's actually getting them out of that position, and that helps their pain. Again, we focus too much on the diagnosis and not the symptoms. Okay, so yeah, I know it's pretty cool when we nail a diagnosis. It feels pretty good, but we shouldn't necessarily focus on that. We should always focus on the symptoms, okay? Because everyone's injury is different, and everyone's going to respond differently as well, okay? So just because they have, a disc injury doesn't necessarily mean you go treat all disc injuries the same. Again, we give too much information. Like I said previously, like everything's out of line. This muscle's not working. Again, keep it simple. Muscles are tight. We need to stretch. Again, I was guilty of that kind of beforehand. I always give the upper trap stretch, but why? For example, a lot of the time that upper trap could be weak, and I could just be inhibiting it more. For example, and if you look at the way a lot of the time with people with neck pain are, their ears are in front of their shoulders. Okay, that means the upper trap is already in a lengthened position, and I'm sitting there stretching it, making it more lengthened. So is that really good practice? We let the MRI influence us. Again, when I was a little more junior, maybe back then I would have let the MRI kind of guide my treatment a little bit more. But now, like I said before, if I don't see anything majorly abnormal, then or the kind of surgeon hasn't told me anything abnormal, then I will be okay with it. I will educate the patient on the radiological findings and how it's normal. And the big thing is first, do no harm. Okay, you don't want to give an exercises too much. Always try your exercises or your treatment firsthand. Start low level and then work your way up. Because the last thing you want to do, especially on a first treatment, is flare them up, and then they're not going to come back to you, and they're going to lose confidence. So, really kind of gone through with this treatment exercise kind of program, but I'm going to go through it again. Okay, a little bit more depth. So, like I said before, use the symptom modification as a guide. Use your objective to guide your treatment. Centralization of those symptoms, really, really important. You don't want them going further down the arm. It means you're probably going the wrong direction. I'll talk about a little case that I had recently, because we're going to talk about a patient's lifestyle and goals. Very busy person, ran their own business, started getting arm pain down their arm for about a couple of weeks. And what happened was basically we gave them 2 exercises to do, okay, because I knew they were busy. I knew if I gave them a big rehab program, they weren't going to do it, okay. And we found that literally side bending away from the pain and lifting the arm up and extending up 10 times, moving that scapula, engaging the serratus and the upper traps, was able to reduce his pain and get it away, and he's doing very, very well. So keep it simple, keep it in their lifestyle and their goals. We've already gone through, just as if it was tight doesn't always mean it. Now, some studies here show that strengthening exercises, particularly for the neck, is a little bit more superior than just stretching and endurance exercises. So I would, personally speaking, if you can't find any symptom modifications, do some neck strengthening, okay? Look up your neck strengthening exercises, look at the varieties, because you're limited by your imagination with this one, okay? And then obviously, of course, review your exercises during the treatment, okay? And obviously, I would say personally, particularly with the neck and discs, I would review them earlier on. And I know obviously it's difficult for a lot of people's practice, particularly when I was working in the NHS. I might have to see a patient a little bit 2 or 3 weeks later, maybe even longer than that. But if you get the opportunity, if you can review them in the first couple of days, it means, and they're having slight improvement, or there's not necessarily a big change, that's a brilliant thing. It means you're on the right way to getting that patient better. But if they do flare up slightly or they get a little bit worse, then you know that your first assessment wasn't on. Education, big one here, right? We've been going through it this whole presentation. Calm those beliefs. Movement is key, okay? Good and key. Our bodies want to move. Pain doesn't mean damage, okay? So remember also when we're doing our exercises, especially if someone's quite anxious and got quite high pain levels, if you're working with a 2 to I'd say 4 out of 10, you're okay. If anywhere like 5, 6, and 7, then they're just going to get too anxious. Also, you might actually be causing a little bit of irritation or nociceptive pain there. Then you're going to obviously educate again when posture can cause pain. Educate on the healing process, particularly with your acute patients, and also the chronic patients as well, saying about that this area is already healed. So whatever was there is now healed, but now there's something else that's obviously irritating. Manual therapy. Okay, now I like doing manual therapy. Okay, and I know my patients like doing manual therapy. Some patients don't want it, don't necessarily need it. Okay, but patients do want it. Okay, they like a therapeutic touch. Okay, maybe the research out there is suggesting more on the exercise therapy and getting them to manage it on their own. Okay, which is obviously what we want. But when someone comes to you as well, they do think that you need to use your hand. Okay, so use that therapeutic touch, mobilization with movement. And again, sometimes, like I say, I use my manual therapy to guide my treatment. Okay, so I might do some mobilizations on the lower cervical. Okay, and it gives them an improvement in movement. Okay, or it reduces their pain. Okay, perfect. Let me give you an exercise that helps mobilize that area with some mobilizations and movement. Okay. And we also know manual therapy does help reduce pain. Right. Other treatment modalities that I may use. Okay. So I may use some acupuncture and dry needling. Okay. Acupuncture I may use when people are particularly painful alongside with maybe electrotherapy, because we're using the pain gating theory. Dry needling I do use and I do like it. I tend to use it on people that I know can tolerate the pain a little bit more, generally with more like the athletes. And again, it kind of helps with that pain, those kind of pain levels. Manipulations, I tend to leave more to our chiropractors and osteopaths, particularly my chiropractor here at Roy Hammond, and Mona, my osteopath. We do some traction exercises, but yeah, at the end of the day, the research again is not kind of swaying us towards much on the traction side, but I may do some manual traction. I wouldn't necessarily, we don't really have a machine at the clinic to do kind of traction itself. And again, we're moving more away from that. Medication is a big thing to advise patients on. Okay, it helps them get them through their exercises. Also, a lot of time when people have radicular type symptoms, we're giving the wrong medication. We're saying, oh, you need to take ibuprofen or you need some paracetamol to help with that. But in actual fact, that's not going to do anything. Okay, so you need to, your neuropathic medications, your amitriptylines, your gabapentins, your pregabalins. Yeah, they're going to be the ones that help. Amitriptyline is particularly good when people are suffering with the night pains or they're waking up with it. So just good heads up. Now, working with an MDT. Okay, so my advice to any of you guys is you find yourself a good team, okay, that you can trust, and you will get so much better kind of patient outcomes. Is unbelievable. Okay, so for example, the Lancet guidelines for kind of is more for lower back pains, but the spinal kind of guidelines at the moment is, especially for chronic pains, is they need to have some CBT help. Okay, and like the psychotherapist at our team, Sean, is really good. Okay, and I will talk him back and through what the patients told me and how they're feeling, and he will tell me as well, and then we can help them on both fronts. Okay, osteopaths and chiropractors, a good one, are worth their weight in gold. Okay, because they can help give that short-term relief to allow the patient to get their exercises going forward. Okay, podiatrists maybe not necessarily used much for kind of cervical pain, but they're very good with regards to biomechanics and looking at what kind of areas that we might need to work on that could contribute to their neck pain. Now, pain consultants, I do work with a particular pain consultant at Complex Spine, a guy called Norman Kufakwara, really, really good. A lot of the time I'll send in patients there when I feel like they need a referral for kind of medication stuff or potential injection therapy, so like a non-responsive kind of radicular type symptoms. And again, because obviously we can't prescribe, so medication, I will send it to Norman. He'll get the medication sorted, or if he feels like an injection is needed, then we can get that sorted as well. And again, helping that patient get to their goals. And then having a good relationship with a spinal surgeon. Again, at Complex Spine, there's some really good guys, just to name a few, Saidi Daftab and Ramesh Nataraja, very good. I can always speak to them. If I have any queries about a patient of theirs or mine, again, they can help guide you. If there's more of an invasive kind of thing needed, like surgery, and you feel like, or something's not quite right with this patient, then they're the perfect people to send to, okay? But yeah, that's one of my biggest recommendations, guys. Really find a good team, okay? And make sure you just work very closely with them in communication, because we are very guilty as physiotherapists or even practitioners, all practitioners, that we want to keep our patients because we feel like we're the best for them. But sometimes it's, we got to let go and let them see other people in our team that we trust. So, guys, that's the end of the presentation. I hope you enjoyed it. If you have any questions, I'm happy to help. And let's go for it.
Thank you so much. I hope I'm audible. Am I audible? Yeah. So thank you so much. It was an amazing session. Like there was a lot of brush up for me, and you have simplified it so well that it was easily understood by a lot of people, and we are already getting a lot of comments appreciating the session. So now we'll be having quick question and answer round, and I want all the participants to start asking their questions, and I'll just read it out to you so that you can answer the questions, right?
Yeah, go for it.
Okay, before starting that, I would like to welcome Dr. Syed Aftab, a spinal surgeon from Complex Spine. He's a very renowned surgeon, and I'm so glad and happy that you have joined us over here. And also, I would like to welcome Dr. Minal Abbas, Musculoskeletal Director of London Pain Back Clinic. So it's a pleasure to have you all over here, and thank you once again for sparing time for all of us. So without wasting any time, let us move to the question answer round. And so guys, you can just start putting down your questions. Let us just start with it. Okay, so we have the first question. So from Avni Gangar, can you put light on differential diagnosis for discogenic neck pain from thoracic outlet syndrome with chief complaint of neck pain?
Hang on, so the question's asking how would I differentially diagnose the two?
Yes.
Okay.
Yes. With the chief complaint of neck pain. So is there any specification for that, or?
I mean, there are special tests for thoracic outlet syndrome, but if I'm getting any kind of referred symptoms down in the arm, then I would always suspect, first of all, the neck. I would obviously look at the neck first of all and see if I can manipulate any symptoms from it. But then I may look at thoracic outlet syndrome by doing your tests like your arm pumps and stuff like that, and see if that contributes. And again, but the thing is that it's a similar thing to what I said before, is that if you can modify their symptoms and improve their symptoms, then it doesn't necessarily matter about the diagnosis itself, okay? Because you're looking, that thoracic outlet syndrome is in the back of your mind. There's a potential there. Same with discogenic neck pain, okay? But I'm looking to improve those ridiculous symptoms, okay? So like I said, less focus on the actual diagnosis, more improve how I can affect the actual symptom here, so I can get a better treatment goal, if that makes sense. Because a lot of the time when we are as practitioners, it's difficult to get it on the first, a good diagnosis on the first time. You can, but it may take a couple of sessions to get that, okay? And again, like I said before, focus on the neck first of all, and then you can try and do the tests around there. Okay, but okay, like I said, is focus on what improves the symptoms. Makes sense.
Thank you so much. I hope it's clear. So we have another question that can you elaborate about the thing that you have said earlier that you are selling yourself? Actually, two students have asked the same question. So I think you can just explain it a bit for them again. You
That's
have
it.
mentioned this in the subjective assessment part. Yes.
Yeah. So you're talking about selling yourself, yeah?
Yes.
Okay, so for
Yes.
example, you know, in everything that we do in day-to-day life, when you interact with someone in a way, you have to sell yourself. You know, if you want to get the best out of them, particularly with patients, because they're trying to find a person to set, like, to help them. Okay, so if they don't trust you, okay, then you're not going to get a good outcome, because they're not going to listen to what you're going to say. They're going to get frustrated, and they probably might not come back again. So, like I said, it's about the way that you interview with the patient themselves. So you listen to them. You make sure you listen through the whole the subject, like what they're saying themselves. You make sure you ask appropriate questions. You make sure you nod, say yes, and you keep things simple for them. Okay, so they can understand it, if that makes sense. All right. The easier that they understand it, and the better that you're going to sell them. Again, it's just general, like, look up interviewing techniques. That's a good way to practice it. For example, eye contact, a big thing. But yeah, just literally listen, good responses, and keep it simple. That's what I recommend.
Thank you so much. I hope it's clear. So we have the next question over here. How to know? How can we differentiate maybe that whether the tension type headache? Sorry, how to differ basically a tension type headache from discogenic pain? So
Well, the headaches at the moment, there is, I mean, the problem is that the majority of headaches at the moment are, how can I put it? A lot of the time, they're more cervicogenic. Tension headaches are a completely different type of thing. And cervicogenic headaches only kind of make up 10%. So if they've got headache type symptoms, it could be potentially something else. It could be cluster headaches, migraines, for example. So always think about that first of all. But if you think it's discogenic pain, then you need to know your referral patterns, okay? And then you work around that region themselves. And say, for example, you could do a treatment on it and see if that improves symptoms, or you could do you could try and aggravate it, see if that increase symptoms. And if you're thinking, then that could be discogenic. But again, remember, we don't focus necessarily on the diagnosis, because it could be anything. It could be the facet joints. It could be the discs. Yeah, it could be the muscles. Yeah, there's no point thinking it's a disc injury. Again, we're trying to improve those symptoms. We're modifying to improve symptoms. Okay.
so can you just can you just elaborate a bit on this thing, because we have a lot of students attending it, and I want them to be clear with it. Is there any difference between cervical radiculopathy and discogenic pain? So just if you can explain it for the students.
Well, radiculopathy is when you get full-blown neuro symptoms. You get the weakness, and you get obviously the kind of nerve symptoms down the arms. Discogenic pain can be anything. It could be just referred symptoms around the tops of the shoulders, around the shoulder plane. It could be just general localized neck pain. Okay. Like ridiculous symptoms is when you have the neural kind of component to it. And radiculopathy is, full-blown radiculopathy is when you've got global weakness and you've got lots of pain down there. What I'm saying is that basically disc pain in general, it could be just general neck pain, or it could be anything around the shoulder blade. Personally, that's about it really. Like there's not much else on it.
So I think that's clear.
I mean, so the disc itself could be causing the radiculopathy, but there's no way of knowing without an MRI, for example.
Okay. So I think we'll just take one or two questions more, because we are already we, we have completed an hour. So patient. Okay. Uh, Okay, which kind of, actually someone is asking this repeatedly, so I'm asking you because we want everyone to actually be happy before leaving the
Oh, no, no,
session.
no,
Two
it's fine.
things.
It's fine. It's good. It's
Yeah.
good.
So two things, very basic things. Any specific ergonomic advice just for discogenic pain, like as we have for different kind of pain? And secondly, like what pillow or bed specification? Basically, it's a generalized thing. But since we're having
No,
repeated
no, no, it's
questions,
fine. It's fine. It's
so
fine.
yeah.
It's a good. It's a good question. It's a good question. Right. So, like I said before, say for example with ergonomics. So we can look at this, like, for example, if there's a change in load, so if someone's changed their seating position, you want to get them, used to what they're used to. So if they changed their seat recently, then that could be an issue. Or they need to find a height that's they're comfortable, something with enough, lumbar support, and they need to necessarily monitor their position they're in. So if they found that they're creeping forward closer to the desk after half an hour, they need to stand up, have a little walk around, okay? And there are a few kind of exercises that you can do to kind of keep the neck working, for example, which is what I recommend for my desk-based workers. But again, it's about educating the patient about the posture that aggravates their pain, okay? Because remember, posture is not necessarily a cause of it. It can be an aggravator, but also educate them on actually having rests at the desk, and also educate them on the amount of time, or them to record a time that aggravates their pain, if that makes sense. So say, for example, they start getting a pain after an hour. So maybe you should stand up every 45 minutes, have a walk around, or do some of your exercises. Is that more what you're looking for?
Thank you so much. Yeah, so I hope it's clear to all of you. Can Okay, I think we have almost cleared a lot of questions. And if there are any more questions that you would like to know, you all can drop a message in the WhatsApp group that we have formed, and I will direct it to Sir so that he can answer anything specific if we want to know. But we are already running short of time, so I think we can just wrap it up. Once again, first of all, thank you so much for giving us time, and it was a wonderful session and everyone loved it. I loved it because you have explained it in such a simplified way, and that's what basically we look for, something that we can understand and something that we can grasp. So thank you once again, and we are
No
looking to
worries.
actually learn more from you in future. This was just an introductory session. We have not actually gone much in detail. Sir has just explained to you about the introductory part, like about how to go ahead, which was really, really informative. And we are looking for more future sessions with you, definitely. And thank you to all the participants for being a part of this. We will try to bring up more sessions for you all. And I want you all to please subscribe my channel so that you get all the notifications for the upcoming sessions. So thank you all, and good night. Take care. Be safe. So, sir, if you want to say anything to them,
Oh
you can
yeah,
just.
perfect. Thanks guys for viewing today. Really, really nice to be here as well. Like I said before, you can always follow us on at London Back Pain Clinic. And if you guys want to do any kind of mentorship work, ping us an email or kind of ping us a message on Instagram, and we'll
So
be
I
happy
can
to
just
help you.
re-explain this. Those who are residing in UK or plan to go and study in UK or something like that, they have student shadowing programs over there. So if you guys are interested, you can just follow them on Instagram page, London Pain Back Clinic, and you can connect to them if they can help you with any student program that you have over there. And thank you so much for actually conveying that to us as well. So thanks again. So we can just wrap it off. Thank you, everyone. Good
No
night.
worries.
Be
Thank you.
safe.
Good night, guys. Take care. See you later, guys. You okay? Me ending the meeting, yeah?
Yeah, I'll just.